All right, so the next thing I want to talk about is chromosomal abnormalities. So the genes are on chromosomes, and genes are transmitted from generationally. Chromosome abnormalities are when the genetic material in the chromosome gets copied incorrectly somehow. So they're not transmitted generationally. They are they occur when the chromosome is copied incorrectly in the process of conception. So first, autosomal chromosomal abnormalities. All chromosome abnormalities are going to occur during cell division. Autosomal chromosomal abnormalities affect all of the non-sex chromosomes. Sex chromosome abnormalities affect X and Y. So they may be expressed differently in genetically male or genetically female infants. The first thing is abnormalities of the number of chromosomes. So euploid is a cell with the correct number of chromosomes. Okay. That cell will have, or that zygote will have received the same number of chromosomes from the sperm as from the oocyte, and so they have the correct number of chromosomes. Monosomy is when a normal gamete, either the oocyte or the sperm, unites with a gamete that has a missing chromosome at some place. So the individual will only have one of that chromosome. Okay. Trisomy is when one gamete has a normal set of chromosomes and the other gamete has an extra of one chromosome. So the most common form of that is trisomy 21, which leads to Down syndrome. Okay. Now, Down syndrome can happen from other trisomies, but the most common is trisomy 21. We also will sometimes see trisomy 13 and 18. Both of those usually result in really severe disability. Trisomy 21, the disability may be less severe, but there is also some risk of congenital heart defects. Mosaicism is when some cells in that offspring, that person, have abnormal chromosomes and some do not. So one is they got that particular chromosome from one parent, the other parent, the gamete did not have that chromosome, so they were missing one. That's monosomy. Trisomy is when from one parent, they got one chromosome, from the other parent, they got two of that particular chromosome. So instead of having two, that person will have three of that particular chromosomes. We also can have abnormalities of chromosome structure. So we can have the right number of chromosomes, but some genetic material may get moved to the wrong one. Sometimes we may have duplication of some genetic material. We may have a copy paste error. We have some genetic material that's duplicated too many times. We may have deletion. So sometimes in that process of cell division, cell division and then the union and then further cell division, we may have some genetic material that's deleted. Part of a chromosome may be deleted. One example of that is called Cretachot Syndrome, and that's when part of chromosome 5 gets deleted. We also can have part of the chromosome arranged in reverse order when that cell division happens. When we look at sex chromosomes, we can have either missing or abnormal genetic material either on the X or on the Y chromosome. Turner syndrome, for example, is an infant that has one X chromosome and no sex chromosome from the other parent. So it's called monosomy X. So female characteristics are going to be expressed, but there are some differences. There are also some syndromes in which there is an extra Y, there's an extra X. So Chromosome abnormalities occur in cell division, and fertilization is somewhere in that process. And typically what we're going to see is there's an issue in cell division while the gametes are being formed, and then when those gametes combine, then we see the expression of that. So a lot of times families who know that they have some genetic predisposition, or know they have some genetic illness in their family, or they know they have a predisposition for chromosome abnormalities. Like one example is women over 35 to 40 are more likely to have children with Down syndrome because that chromosome abnormality becomes more common as we age. So people who know they have those risks might seek out genetic counseling and testing. So how would we do that? If we're in the position where we're trying to help parents determine their genetic and chromosomal risk for reproduction? We want to start with history. And a lot of times getting a 3-generation family history can be a cost-effective place to start. So you start with that couple and their siblings, and then you move to their parents. And did anyone in their parents' generation have any chronic illnesses or any unexplained illnesses or deaths? And then we move to the grandparents. And we may not always have names for what's happened, but there may be a history, for example, of people who died at a particular age and had a certain set of symptoms that now we can look at it and think maybe that was this particular disorder. So a 3-generation family history is a cost-effective place to start with screening. There are actually some tests that can do some genetic risk estimation. There's testing available for particular genes if a family is at risk. There's counseling to help clients understand their risk and make decisions about reproduction based on accurate information. That's really important. It's not our job to tell people they should or should not reproduce, but it is our job to make sure they get accurate information to make those decisions. General preconception care for everyone. Patients are going to have better reproductive outcomes if they are healthy when they conceive and through the pregnancy. So we want to help people to optimize health. And one major thing is folic acid supplementation. Every female person who has the potential to become pregnant should probably be supplementing folic acid because if a pregnancy occurs, there's a risk of neural tube defects. Okay, we're going to move to conception and the process of conception in the next video.